we Indians and Southeast Asians have the reserve and the AMH going down almost 6 years earlier than the Caucasian counterparts. Maybe it will be just a torsion of the ovary or a cyst in the ovary.
Couples going in fertility treatment, do they get a day off, a paid day off or a treatment day off?
Even alcohol up to moderation is fine, but smoking will reduce drastically. We take out the cortex where we cut it into very, very small pieces in the lamb and then put it back in the ovary.
Dr. Nayana, before we proceed, I've been following your journey for a long time and what you're doing. Beyond the hospital, you're doing a lot of social initiative, you are spreading awareness. And for that, I cannot comment enough and I cannot thank you enough for everything that you and Akanksha Infertility Clinic are doing. The entire family is involved in this business and I'm so heartened to see that.
Thank you. Thank you. Thank you for your kind words.
Dr. Nayana, there are so many talks going on about premature ovarian insufficiency, egg quality, sperm quality. So today I want to discuss low AMH. The first question is, how do we assess female fertility?
The female fertility, if you see the quality of the egg, the first is the age of the female. Older the age, the fertility potential goes down because the eggs are there by birth. It's not new development or manufacturing of the eggs. So older the female, the egg quality will be weak because of the aging effect, which happens on all the cells of the body. Second is we go and look on the ultrasound scan, how good is the ovarian volume and the number of antral follicle counts. Third is the measurement of Anti-Müllerian hormone, which is an ovarian reserve marker. Even FSH of day 2, estradiol level, are the two markers which we can look at. But this is basically how we assess the female fertility.
AMH, what exactly is this? And how good is it at predicting fertility in a woman? How reliable is it?
Okay, so AMH is a marker, biomarker, which shows the ovarian reserve. How many eggs are there? There were millions at the beginning. By the time the female is menopausal, it's just 1,000 or so. So it will tell you what is that ovarian reserve. Now, the good part is that it does not fluctuate like the FSH during the menstrual cycle, very minor changes.
Okay.
So AMH of 3 months or 1 year should be valid in younger and older patients of 3 to 4 months. But the thing is the assessment and the validation of the AMH measurements. So there are different platforms. The ELISA platform is not so good. Vis-a-vis, if we see the other platforms, the next generation ones like the Roche and the BD platforms, they're really good. So the way the AMH is assessed and the lab in which it is assessed is very, very important. Even to the extent that how much time the sample is kept, when the sample is run, all this small detailing also is very important when you analyze the AMH and interpret its result.
Like you mentioned, it's valid only for a few months to look at it.
In older patients, younger patient up to 1 year, it could be valid.
So if an older patient comes to you with a 1-year-old test, then that's no longer valid?
No, I would want to repeat it.
Yes.
And if the patient undergone surgery or had some major illness and suddenly I see the size drop out on the ultrasound, I would want to repeat it earlier.
You mentioned age. At what age do AMH level starts declining?
AMH till the age of 24, 25 increases, then it peaks.
Okay.
After that, gradual reduction will be there. But after the age of 35, it starts dropping and it starts dropping almost perpendicular. By the time of 40, it's very low. But here we have to see the ethnicity. Like we Indians and Southeast Asians have the reserve and the AMH going down almost 6 years earlier than the Caucasian counterparts. So for us, I would say if they say 37 is the age when it drops, I would say that by the age of 32, the count will go down. And by the age of 35, the quality also will start deteriorating.
Oh, that's remarkable. How is that?
That's remarkable. Yes, we can't go by the Western data.
Exactly. And that's so shocking. Now, why is there such a difference in terms of ethnicity?
I mean, the ethnicity plays a role genetically in a body. So it is said that like the Black Africans have huge number of fibroids, which the Indians don't have. PCOS is more prevalent there. The same way, the ovarian reserve in an ethnicity, it could depend on the environment, it could depend on the dietary aspects, on the genetic aspects, but that is a huge difference when you see 6 years biologically, we advance faster than the Western counterpart, Caucasian counterpart.
All the more reason for people to hurry and have children.
Yes.
Beyond age, then, are there any causes of low AMH levels?
Yes. So the low AMH will be when a person is suffering from autoimmune disease or had a cancer therapy taken before, any toxic drugs like that, especially cancer drugs are really toxic. Then endometriosis, which is becoming very prevalent. So endometriosis, also the ovarian reserve will go down. Then any surgery in the ovary, maybe it will be just a torsion of the ovary or a cyst in the ovary is removed, benign or dermoid, the AMH would go down because those many follicles will come down. And then sometimes long duration of drugs that they have taken, like a long duration of birth control pill, but then that is reversible.
Okay.
And the lifestyle is very important. Smoking reduces it drastically. Even alcohol up to moderation is fine, but smoking will reduce drastically. Then very low BMI, very thin patients and very obese patients again have the issues of low AMH.
So in terms of AMH, smoking is the bigger culprit than alcohol is?
Yes, absolutely.
Can a younger woman with low AMH get pregnant naturally?
Low AMH does not say that you cannot conceive naturally, whatever may be the age. But younger the female, low AMH does not matter much because the quality will be good. The aging effect on the egg is not there. So if I get 3 eggs from a female who is 29, I will get a pregnancy. But if I get 3 eggs from a female who is 42, I may not get a pregnancy. So age-related AMH is how we interpret.
Okay.
For a female of younger age group, I would expect that the AMH should be 2-3 nanogram per ml. But a female of 40 comes to me and she has 1, I would be very happy. So one is age-related interpretation of the AMH. That is the count, the number of eggs I will get. I'll be happy. But quality, again, is defined by the age. So a 45-year-old woman with a good AMH can give me 15 eggs, but all of them can be abnormal embryos. And a young female with a very low AMH can also give me a normal blastocyst and a normal pregnancy. So AMH with age should be interpreted, and that is your question, absolutely, that younger female with low AMH should not jump onto IVF. They can still conceive naturally, and it's a fact.
Quality over quantity is more important.
Yes.
Beyond smoking, are there any health lifestyle changes that we can implement in our life to improve our AMH levels?
Stress also is a very big culprit. Stress can also reduce your AMH. So lifestyle modifications in the form of eating healthy diet. The calories and the fried and the processed foods should be thrown out. Absolutely no. If you want to improve the quality of your eggs, go for more greens, naturals. That is very important. Your daily routine is very important. Late nights, etc. should be stopped. Exercise plays a major role, especially aerobics, high impact exercise, which increases the blood flow to the ovaries. Weight loss if you are obese, and weight gain if you are very, very thin. And supplements. These all will help you improve, at least to a certain extent, the AMH and the quality of the eggs.
A holistic approach is needed, but it's not
absolutely. And then you can also go for acupunctures, which is also giving good outcomes. Detox, yes, and supplement.
Okay, but this is not a guaranteed way of increasing AMH level, also, correct?
It is not. Nothing can increase your AMH drastically, but definitely it can improve it. And nowadays we look into a lot of regenerative medicine also.
Okay.
Which is the PR and the stem cell therapies for low AMH.
Yes, I'll come to that. When we talk about greens, leafy vegetables and all, nothing is green or nothing is really organic anymore, isn't it, Dr. Nayana?
Yes, that is again the lifestyle. I would say that we should go and search for organic foods which are now available, fortunately, and people are proving it that it's organic, no pesticides. So we should try and find that out. And the rest is how we prepare our food. It depends on that. So we cannot depend totally on it, but at least we can try that out.
Yes, yes. Got it. Is there a connection between, let's say, Dr. Nayana, low AMH and early menopause?
AMH will not predict menopause, but definitely it gives an idea or a hint that maybe you can get early menopause. You cannot 100% predict menopause by the AMH. As you cannot predict 100% pregnancy if you have a normal AMH.
Yeah, that answers it. We are talking about low AMH, low ovarian reserve. What treatment options, you said stem cell research, and also what treatment options are available for a couple with low ovarian reserve?
So when the female has low ovarian reserve, after the holistic approach, you go for the supplements. So the DHEA, though there is controversy, but majorly it is accepted. The DHEA supplementation for 3 to 4 months in the dosage of 75 milligram per day is good. Then the androgen gels, because testosterone is very important. Androgen forms the substrate for estrogen, which is going to give the volume and substrate to the ovary to create eggs, to have those eggs. So androgens supplementation 3 months prior, CoQ, coenzymes, omega-3 fatty acids, and most importantly, if we look at the vitamins, it's vitamin D. There are studies which have shown that vitamin D supplementation can improve the AMH levels. So these all supplements are very important. After that, if we go beyond this, then we have to look into the regenerative, the platelet-rich plasma and the bone marrow-derived stem cells, and the in vitro activation of the ovaries. These are the 3 methodologies which can help improve the ovarian marker. So platelet-rich plasma, you take the blood from the female, about 30 ml, create that platelet-rich plasma with a technique, activate it, and then inject in both the ovaries, and then wait for 3 months to see its effect. We have seen natural conceptions after this in AMH as low as 0.04 in a female of 25 years. So that is one thing important, though we have to rule out the genetics, because if the female is a fragile X carrier or if she's a Turner syndrome, these are the genetic aspects, then the AMH could be low. And in certain families, if the menopause starts early, the AMH can start reducing in a female at a younger age. So if there's a female whose sister and mother had early menopause, she should get her AMH checked earlier in the life to see that it is normal.
So genetics do play a big role.
Genetics do play. It is in the heredity that if my mother had menopause at 37, I may also have it at the same age. So my AMH will start declining faster. But my mother conceived easily because that time they used to have an early marriage, early pregnancy. Nowadays, marriages are delayed. Planning of pregnancy is even further delayed. And that's why we see a lot of low AMH coming up, right, in the practice. Then bone marrow is the bone marrow which we take from the iliac crest. We take out the concentrate of the bone marrow, separate the mesenchymal cells, which have got numerous growth factors, which are very robust, and that we inject in both the ovaries, either ultrasound guided in both the ovaries, or we do it laparoscopically and inject in both the ovaries. The third technique, this in vitro activation, is for very, very low reserve patients who have good volume, but their AMH is very low. Maybe they're having periods of amenorrhea also. In these patients, we do a laparoscopy. We take out the cortex where the eggs are there, the secondary follicles. We cut it into very, very small pieces in the lab and then put it back in the ovary. So there is a disruption of hyposignaling, and that will help in stimulation of and activation of the dormant eggs in the ovaries. So these are the recent advanced techniques where we could have a female conceive at the age of 47 with her own eggs. So these incidences do happen.
Fascinating, fascinating. And this is like a sci-fi movie. You talked about plasmacyto treatment. Is this the same as ovarian rejuvenation?
Yes, ovarian rejuvenation with platelet-rich plasma, ovarian rejuvenation with bone marrow-derived stem cells, and ovarian rejuvenation mechanically with in vitro activation of the ovarian cortex.
Is this a safe approach to fertility, or?
It's pretty safe because Plasma, platelet-rich plasma is just, it's being used everywhere for the dermats and the hair and skin and everywhere. The bone marrow-derived stem cells have been used in a number of medical conditions, from osteoarthritis to neurological conditions. And here, the mesenchymal bone marrow stem cells are multipotent. They do not have tumorogenic activity, so they are very safe. And in vitro activation in last 10 years, 100 babies have been born through it. So that is the last resort for a very, very low AMH in advanced stage females.
Oh, I wish everywhere in India we had this kind of treatment facility. Like, I'm from the Northeast, and I know of one person who has got 0.1 AMH, and she's been asked to arrange a donor. And
that is the last option, last we advise, yes. Yeah. But there are so many females who want to conceive a baby with their own eggs, and exactly. I understand that.
Exactly, ma'am. Exactly. Now, ma'am, I was reading an article, and it said that by the time a woman reaches 30 years of age, 88% of her ovarian reserve are over. So from 30 years on to the remaining fertile period, she's surviving on 12%. Now, it is known that all females have a fixed set of eggs, and it declines with age. At the same time, women are very career-oriented. Despite what doctors like you say, have babies, women still think, we can still plan for a baby later on, at a later age, like maybe in the late 30s, early 40s. Is this too late?
Have the science advanced? We should go for social egg freezing. Again, there is a controversy how you can guarantee, but at least I know that I have an insurance. I have frozen my eggs when I was in my early 30s. Mm-hmm. Before 32, up to the age of 36, 37, it is said. But I would say that before the age of 32, and now so many females are coming up to preserve their eggs, to preserve the embryos, if they have a partner or married and they're sure that they want to have a baby with them. And even to a certain extent, preserving the ovarian cortex. Mm-hmm. Just recently, we had a female who had a huge ovarian cyst, and she was being operated in a public medical college, and the other ovary was very small. And when she was taken a few days before, we counseled her to preserve the ovarian cortex of the opposite ovary, because there is no time to stimulate with a huge cyst of 30 centimeters. She was 37 years with AMH of 0.3, and she agreed. And we did that. And now the tissue is there. As soon as she gets married at 38, 39, 40, whatever, we are at least hopeful that we can have those eggs. So social egg freezing should be considered when you are delaying a pregnancy and a baby.
There you go. Dr. Nayana Patel giving hope and inspiration to women who are of a late age, as always.
Yes, 100%.
The last time we spoke, Dr. Nayana, I asked you a question on divorce on the grounds of infertility. Today, even though it's not related to our topic on AMH, I want to ask you a generic topic. When a couple undergoes fertility treatment, do they have a paid day off or a treatment day off? One. Second question is, are their treatment costs reimbursed or covered by insurance?
Yes. So there are certain companies, why I call up a couple. There are females who are being offered egg freezing by the corporates because they know that she's going to delay. So that is one very good thing the corporates have included. Paid leave off right now, I have heard, is only in India, in some states and in Spain, they have given as a blanket for menstrual pain and dysmenorrhea during their menstruation. But paid leave off for IVF, I have not heard of. Maternity leave, yes. Regarding the insurance, now there are corporates coming up for sponsoring the IVF treatment for their employees. Mm-hmm. So that's a good sign, because they feel that this is one thing that they need the support. Second is, there are banks that are coming up with insurance policies, EMIs, based on the payslip. Like a couple cannot give upfront 1.5, but they are in the certain payslip, they get an EMI, which they pay to the bank, and bank takes something from the clinic for that and they give it. So lots of EMI sponsored by the banks are coming up. Government so far is working on it, but has not thought of it. Recently, I read somewhere that they might include in the Ayushman Yojana, but we don't know. But this is the progress so far. And many government colleges are opening up IVF centers to help the people who need that support.
And which will be cheaper, the cost?
Which would be yes, cheaper, much cheaper if the government opens it up. But it's not yet started on a big scale.
You mentioned bank-sponsored corporate world. These are all fine, but these are not really reachable for common people or for certain income bracket people. No hope for those people?
No, we get patients who come for IVF, and when they have a good job profile, means reasonable, when they ask for an EMI, we make them connected to the bank, and then these are settled, the EMIs.
That's great. You're doing a great job.
We also have our IVF trust, Savitaben Ratilal Tanna, which is in my mother's name. So where there are really, really needy patients, we give them it at almost 80% cost. 20% we let them pay.
Oh, okay. What is the name of the trust again?
Savitaben Ratilal Tanna. It's in the name of my mother. I'm running this IVF trust to help the very poor people for IVF.
That's wonderful. Have you helped many?
Many, and we still continue that.
This is amazing. This is the first time I'm hearing about something like this in India.
So we have that trust.
So for the trust, the patient party is liable to pay only to 20% and 80% is...
Because I always feel that we make them pay something, they will value the importance. If it's 100% free, they may not value it, because here you have to take post-transfer care, everything, they will do it if it's a 20% slab that they are paying.
You are based out of Gujarat. Now,
yes, in Anand.
Is this applicable for everyone within India or only for Gujarat state?
No, anyone who can travel here, we can do it if they are really needy.
Amazing. May God bless you and whatever you are doing more, Dr. Nayana. Thank you so much for your time. Even if today is a very auspicious day and you're so busy, you have given me 40 minutes of your time. I am beyond blessed. I'm beyond happy. Thank you, Dr. Nayana.
Thank you.
God bless you.
Have a nice day. Thank you so much.
You too. Bye-bye.
Bye-bye.